My name is Joanie Bouchard. I'm the interim Chief Regulatory Officer and Deputy Registrar for the college. We thank everyone for joining us on our fourth licensee webinar to support increasing knowledge towards the transition to the Health Profession and Occupation Act. Today, we will be focusing on the quality assurance and continuing professional development under the Act. The purpose of the webinar is to provide transparent information at the stage that we are at in developing in the program. We know people are very interested in understanding better how this is going to work under HPOA, and we will do our best to share where we are at this point, recognizing that there might be some details that we're not able to provide today. So I'm going to hand it over to Lisa Bannerman, who's the Director for Quality Practice at the college. She will do the territorial land acknowledgement and then start our presentation. So again, thank you for joining us.
Thank you, Joanie. I'd like to acknowledge today that I'm joining from the Vancouver College office on the traditional, ancestral, and ceded territories of the Coast Salish people, specifically the Musqueam, the Squamish, and the Tsleil-Waututh nations. And please take a moment to think about the territory that you're all joining us from today as well, because we know you're spread out across this entire territory that's now known as British Columbia. Okay, thank you. Next slide. So just quickly, this is our goal and objectives for the day. And yeah, I just wanted to start by acknowledging that over the last couple of years, you've all experienced significant amounts of change with amalgamation and everything we've gone through related to that to get to today. And now you're hearing about new legislation with the HPOA and a new program for continuing professional development QA. And I know it's a lot, we know that, but this is also a really exciting time. This is an exciting program, and we're excited to bring all of you along with us on this. The assessment features for this program, its alignment with the HPOA, that it's going to be data informed, and that each year you're all going to help us make it better. It's really important, and I'm excited about that. I also believe it's kind of the first of its kind in Canada when for healthcare regulation, when you consider that it applies to 9 very different professions. So we also know that you have lots of questions and want some clarity on certain things, and that you don't have a lot of concrete details at the moment. I've noted, what we really wanted to achieve for today, and we want to tell you what we know and what we don't know. Next slide, please. So I know what's most important to you is kind of what you can expect over the next little bit with the new program, but I did want to share that we have a framework that we have to consider in the design and development of this new program that's really important. So the Health Professions and Occupation Act is woven through every aspect of the design and development of the new program. The guiding principles are built right into the HPOA. They apply to everything we do, including how we design, develop, and conduct our new program. The HPOA also has some new and very specific requirements for quality assurance and continuing professional development. We're going to speak to that during the presentation, but I wanted you to be aware of that and thinking about it as we start. And so all of these things together is what we're using to inform and guide our decision around this new program. So keep it in mind as we continue on. So let's jump in to where we are right now, and then we'll come back to some of these elements a little bit later on. We are developing and launching this new program in phases. So phase 1, which is the annual continuing professional development touch points, that's what is planned for this fall. This is the part we're working on right now, so we can speak to this in quite a bit of detail today. Phase 2 is the quality assurance assessments. That's not planned to launch until May of 2027. We're not very far along in that phase yet at all. We will speak to both as much as we can in just a few minutes. Also think it's important to tell you that there's going to be opportunities for input into the phases as we are developing them. So there are two activities that are going to be coming up. They're planned for licensees so that you can engage and inform some of the steps. And Kathy's going to speak to that a little bit more in a little bit. And there's going to be additional engagement that we will do for phase two when we get to that development stage. Next slide. Also, just a really quick reminder that for this March 31st renewal, there are no legacy quality assurance reporting requirements. We've had a few questions about this, I think, with renewal coming up. So we just wanted to put out this quick reminder. There's nothing for this one. We are going to tell you today what it is that you'll have to do in order to renew in March of 2027 for quality assurance requirements for continuing professional development. Okay, next slide. So I'd like to introduce what we are calling the Professional and Quality Practice Program, or PQPP, and I'll apologize right now because I know I'm going to mess up on the different acronyms, components, names, because we're dealing with new requirements under HPOA. I still have legacy programs and requirements rolling around in my head. So I find that I mix up these terms once in a while, so I'll apologize now for that. Hopefully I won't confuse you too much if I do. So the purpose statement here on this slide about our new program, again, I'm going to point out that this ties specifically to Section 98 of the HPOA. So this purpose is embedded in the HPOA. And there are three parts to our new quality practice, professional quality practice program. There's continuing professional development annual touch points, practice support and resources, and quality assurance assessments. So this new program will meet the requirements in the HPOA, be evidence and risk-based, and incorporate the principles of right touch regulation. So now I think what we can do is we'll go into each of these in a little bit more detail. So I'm going to start with what I listed as part two, which is practice support and resources, because we have this already. This is not a new thing. We have practice advisors for each of the 9 professions on staff. Practice advisors are available to you to provide confidential advice on things like standards, code of ethics, bylaws, and they're there to help you when you have questions about how to apply these requirements to support decision-making in practice. When you reach out to the email that's noted on the screen, I've had a few people say to me, well, it doesn't identify my profession, so how do I know it's getting to the right person? It is triaged and then goes into the appropriate practice advisor's inbox. So it is going to your professional person when you send it in. And just keep in mind that our practice advisors only work part-time, 2-3 days a week, and the rest of the time they're in clinical practice. So a response may not be immediate. Okay, next slide. Okay, so dive into the components that are new. So the CPD annual touch points is what we are working on developing right now. This is phase 1, as noted on that earlier timeline, and it will launch in the fall of 2026. These are the items that all licensees will be required to complete every year between October 1st and November 30th. You will need to complete everything for the CPD annual touch point before you can renew your license in March of 2027. So the entire PQPP is designed around the standards that you as a health professional are held accountable to. And we've been working on a set of harmonized standards for the 9 professions. Thank you to those of you who completed the survey on the new harmonized standards that we sent out in November and December of last year. We had good participation and we have lots of feedback. So it's currently being analyzed and It's taking a lot more time than I think we expected because we have such good feedback. And um, with the feedback, some of it will inform changes to the standards before they actually come into force. And other feedback that we've been receiving will help us develop some guidance or guideline documents for registrants to understand how to meet the standards. So all of the feedback is super valuable and will be used in different ways. Okay, next slide. All right, so the first piece to the CPD annual touch points is the standards review. I said it's built on standards. So we have currently in the draft set, I think there's 14 standards. There will be a selection of standards each year for this program. So the selected standards for 2026 are communication, consent, discontinuing health services, and ensuring continuity of care. Those three. The final set of harmonized standards should be available for everyone to see sometime in March, and we'll notify you by email when that happens. They'll be on the website. I'm not really going to speak further to the standards themselves today because we're going to be having another webinar on those on March 18th once we've completed the review, gathered all the feedback and input changes. So for the portion that's actually the standards review, I know I said all of the annual CPD touch points would be completed October 1st to November 30th. This first item is a learning activity to help you prepare for the quiz on the standards. So we're going to make this available actually in September. So just to give you a little bit of advance time to complete the learning activity and be prepared for the other two parts. The estimated time to complete the learning activity is about 30 to 60 minutes. It's going to depend on the number of standards that are being tested on for the year, and how long you spend reviewing the material, really. There's no mark for this part. It is strictly a learning activity. And there will be content that's common to all of the professions and some profession-specific content as well. Our timeline estimate is kind of based on, programs that have similar components. And we'll confirm this when we do pilot testing on this piece, in which I'm hoping will be over the summer. Okay, next slide. So next is the standards quiz. So it's on the same standards. So for this coming year, again, that's consent, communication, discontinuing service, and continuity of care. It is a short, profession-specific, case-based quiz. It'll be open book. It'll give you a score, and there will be feedback provided. So if you answer a question incorrectly, it's going to give you the correct answer and the rationale for why, so that you're learning about how to apply the standards as you're doing the quiz. The goal will be 6 to 8 items, again, profession-specific cases, with about 9 professions per case. So this means for 2026, with 3 standards in the blueprint, 6 case studies, we're looking at about 54 questions. The estimate is that you should be able to complete this and do the feedback review, so review the correct answers and the rationale, in about 45 minutes. We're actively working on the development of the cases and the questions right now. We are utilizing our practice advisors as subject matter experts. So your practice advisors from the 9 professions are developing the content. And then once these items have been drafted into, once they're in a final draft, we're going to be using separate item reviewers from each of the 9 professions to validate that the cases and the questions are realistic to practice in that particular practice setting. We'll be recruiting item reviewers shortly. We haven't started that part yet. And now I'm going to pass it over to Kathy to speak to the sections that she's been doing a lot of work on.
Thanks, Lisa. Hi, everyone. My name is Kathy Silversides, and I'm the manager of quality assurance. So let's talk about the third annual CPD Touchpoint, and that involves completing 2 guided self-reporting activities. One is the inventory of learning, and the other one is the inventory of risks and protective factors. So the inventory of learning, it has 2 parts. One is you're going to report on the learning activities that you have completed for the past calendar year. And second, you're going to document what you anticipate your future continuing professional development will be throughout the next calendar year. When reporting on your completed CPD during the past calendar year, you'll answer a series of guided questions such as the dates and the timelines when that activity was completed, approximately how long it took you to complete the activity, and how that activity relates to the practice standards. And then when you consider looking ahead to your intended CPD learnings for the following calendar year, you'll be asked some guided questions, including one, whether or not you actually intend to participate in continuing professional development, the estimated number of activities that you have planned, and the types of activities that you intend to complete. For example, if you intend to go to conferences, if you're going to be mentoring, if you're doing some self-study such as journal reviews. So for the first year, meaning this fall of 2026, we recognize that some of you may not have established a formal continuing professional development plan for this year, for 2026. We certainly know that for some legacy quality assurance programs that had those established CPD learning plans, such as continuing competency programs or the PEP, may have ran on different cycle durations, such as 2 years to complete your learning plan or 3 years cycle where you may not actually report until the end of your third year. Because of this, we recognize again that you may not be able to provide details of your CPD activities when you go into the portal for the first time between October 1st and November 2026. So certainly we won't perceive the information that you provide as a fulsome report of your CPD, but rather really this first year, the 2026 inventory, is a learning activity in of itself. But in the subsequent years of reporting your learning, meaning the fall of 2027 and beyond, all licensees are expected to be able to reflect on the activities they planned on completing in 2027 that you would have established in your inventory of learning in the fall of 2026. So hopefully that makes sense to you all. So having access to the inventory itself will help licensees understand the expectations in completing this guided self-report. So with that in mind, a little bit of a shout out for the communications team. They're in the middle of working on the next licensee newsletter, which is expected to be published sometime late February into March. In that newsletter, you'll see an invite for all of you licensees to contact the college if you're interested in completing a survey about this inventory of learning. This is a voluntary survey, and it's considered one of the transition activities to help inform the new program. So in the survey, you'll have the opportunity to review and provide feedback on the current version that we're working on of the inventory of learning in the survey itself. If you participate, we would really like you to, because we definitely appreciate receiving feedback, your thoughts on the working version. You will actually have a preview of what to expect before the actual finalized official inventory is launched on October 1st of this year. And I'd like to think that licensees can consider this as a sneak peek and potentially even a jump start to start considering your CPD activity planning for the following year. There'll be 3 sections in the survey. The first one is a bit about yourself. The second one is completing the inventory to the best of your ability and what you've done to date. And of course, providing us feedback about the inventory itself. To share with you that the working version of this inventory was recently shared with members of our Quality Assurance Committee, which includes members of all 9 professions, as well as public members. We certainly received some great feedback. Overall, the messaging was positive and very productive, but we'll continue to refine the inventory as we ready for its official launch on October 1st. I did want to comment a bit on some of the feedback we've received around recording and reporting your continuing professional development. So if you choose to participate in the survey, you'll note that although the inventory does not require you to report the specific number of hours or continuing education credits that you have accumulated, nor will it require you to report a specific minimum number of hours, the inventory still requires licensees to provide the date and the timelines of each learning activity or CPD experience, the type of or format of these activities, and also how the CPD experience supports you in meeting practice standards. So if you've utilized accrediting bodies or your associations to direct which conferences or workshops or other activities you chose in the past, please continue to do so if it assists you in meeting your CPD needs. Continuing education is certainly a critical component to ensure knowledge, skills, and abilities remain current, and that's definitely specified in the new Act. Although the annual CPD reporting requirements do not include reporting a minimum set of continuing education credits, licensees will continue to report on an annual basis their inventory of CPD learnings, demonstrating the intention to maintain and enhance competent practice. Finally, just a quick note to say that this survey is confidential, so no individualized data will be accessed by the college, and only aggregated information that retains individual privacy will be shared with the college. Next slide. And flip ahead one more would be great. Thank you. So the second guided self-report, the inventory of risks and protective factors. So this is a confidential inventory for each licensee's own use to help increase your awareness about risks and protective factors that are relevant to you and your practice, and to help guide you in developing your future CPD. The college won't have access to that information, though, that's entered into your inventory. We are currently looking at a unified new program platform that licensees will enter into to complete their CPD touch points. And that platform will certainly include safeguards to ensure the licensees have confidence that your individual guided reflections around your personal risks and protective factors is for your own personal use. And selection criteria for those of you who may receive a follow-up quality assurance assessment will not be based on your individual information that you have entered in your inventory about your own specific potential risks. In addition to seeking feedback on the inventory of learning tool, we will certainly provide you more information as it becomes available about this particular inventory. It's still very much under construction, I would say, but when we get closer to having a true working version, we'll be seeking your voluntary feedback on that inventory through another survey. So expect more details on that later in the spring. And next slide, please. Okay, so very briefly, a recap here. Lisa and I have shared with you the 3 CPD touch points for the year. So the standards review, followed by the quiz on that review of the standards, as well as 2 guided self-reports on your learnings and your risk and protective factors. We don't expect all 3 components or touch points to take more than 2 to 2.5 hours. The platform will be set up so that you can come and go. You're not required to sit and do all of it all at once. So certainly you can do a part of it, save it, contemplate, come back later. You can go in as many times as you like. The other thing I really wanted to emphasize is although you will be reporting through this 60-day window on these 3 touch points, the guided inventories are based on reflections and intentions for the entire year. So CPD is continuous throughout the calendar year, but the reporting on that is this 60-day window reporting period. And I think we are now going to take a bit of a break. Oh no, actually, let's talk one more piece here. Quality assurance assessments. And then we're going to take a break after this and answer some questions before we move on to more the HPOA and the feedback we received about the bylaws. So as Lisa already mentioned, quality assurance assessments are phase 2 in the timeline we showed, which we're planning a launch for May of 2027. So more than a year from now before we expect to launch this aspect of the program. So designing and developing specific assessment tools and further clarity on selection criteria are projected to commence in the fall of 2026. So as Lisa mentioned, right now, we are very much focused on completing those tools specific to the annual CBD requirements of reporting, but we will shortly turn to developing the selection criteria and the tools for quality assurance. As with other components of the program, we will certainly be consulting and seeking feedback as we design and develop. So research tells us that the large majority of health professionals understand how to apply the standards and are providing competent healthcare services to the public. And we certainly expect that the annual CPD touchpoints that everyone must do will reflect this. Where it's identified that an extra support on applying the standards may be helpful, a licensee may be selected to go through a follow-up quality assurance assessment. These assessments are intended to be supportive and focused on the application of standards rather than assessing technical clinical skills. And quality assurance is distinct from any investigative process. Quality assurance assessments are intended to be a supportive tool, and as the HPOA states, the college needs to ensure minimal disruption of services being provided to the patients during the administration of a quality assurance assessment. It's also clearly outlined in the HPOA that quality assurance assessments are not for the purposes of an investigation or a disciplinary proceeding. And based on the experiences of QA programs that are similar to the ones we're developing, we anticipate then less than 5% of licensees will be selected each year to participate. And as I mentioned, design and development are still very much underway to determine who may be eligible or selected for a follow-up quality assurance assessment. While still early in the design of this assessment, at this point, we anticipate that those selected for a quality assurance assessment will participate in a semi-structured, virtual, and conversational-based interview with the QA assessor. The assessor needs to be of the same profession as the licensee participating in the assessment, and that's actually specified in the HPOA. The assessors will be expected to have the necessary knowledge, skills, and abilities to perform assessments and will require support and training to ensure fair, equitable, consistent, and of course, evidence-based assessments. The QA assessment interview will take place, as I mentioned, virtually, and we expect less than an hour for licensees to participate. The interview will focus on the practice standards that licensees would have reviewed and completed for the practice quiz during the most recent CPD reporting period. And Lisa already mentioned to you what those 3 standards are for fall of 2026. We've received questions and feedback regarding accessing a licensee's records, including confidential patient records as part of the quality assurance assessment process. The ability for a health regulator to access patient records has been long-standing under the HPA and in privacy legislation. I know some of you are familiar with this process. 3 of the 9 professions had well-established on-site and or virtual practice assessments in their legacy quality assurance programs where the quality assurance assessor would have accessed confidential patient records. That being said, Under the new program, we actually don't anticipate accessing patient records as a standard regularly or broadly applied process during the quality assurance assessment. The current Act, the current HPA, as well as the HPOA and college HPOA bylaws are what we consider permissive to allow access to these records. However, any future intent for the QA program to access patient records would require extensive consultation as well as many safeguards. The interest and feedback we've received on this topic certainly reflects the value that we all place to ensure patients are kept safe and to ensure the administration of quality assurance assessments avoids any potential harm or discrimination. While the HPOA and bylaws are broad enough to allow for future possibilities of accessing patient records, there are no plans for us to access patient records for at least the first several cycles of the quality assurance assessment. We've also received some feedback from licensees expressing interest in knowing more about the purpose and process for an assessor to contact patients or family members as part of the quality assurance assessment. As I mentioned, designing and developing specific assessment tools is projected to commence in the fall of 2026 and certainly will continue into 2027, meaning we'll certainly have more information as we go and as we develop. As with other components of the program, we'll certainly be consulting and seeking feedback. But at this point, there's no specific intent to contact patients during the first several cycles of the QA assessments. Again, first launch planned for May of next year, 2027. But to give you a sense of what type of interaction the quality assurance program may have with patients, so patients at large may voluntarily provide feedback about the services they receive from their own health professionals. For example, providing a publicly accessible link or QR code to a feedback or questionnaire may be one option. And as outlined in bylaw, patients would need to consent for the quality assurance assessor to gather information about their patient care experiences. So for 2027, with quality assurance assessments, it's expected that those licensees who are selected will be notified in March of 2027, with, again, assessments occurring in May and into June of 2027. And now I'm going to pass it back to Lisa.
And I'm not going to say very much on this particular slide other than just to recap. CPD annual touch points, that's the requirement for all. We're working on those right now. Practice support already available, so reach out if you have any questions. And the quality assurance assessments, we're not starting work on this until sometime probably later fall of 2026. And that's only for select group. Okay. So next slide. We thought with all of this information, because it's a lot right at the beginning, that might be good to break it up. And if there's any questions specific to, to the components that we just spoke to, we can answer some of those now.
Yeah, thank you, Lisa. I'm happy to jump in with some of the questions we've received in advance. So there's one question here that says, the College of Audiologists and Speech Language Pathologists of Ontario has something called the SAT, self-assessment tool. Is the guided guided self-report similar to this? And I do want to acknowledge it's a profession-specific question on a very specific tool, but I guess some clarity around what the guided self-report might look like.
I'm happy to take this one, Lisa.
Okay, thanks.
So yeah, I think I'll answer so that it resonates with all of you, not necessarily for a specific profession. So I hope that the information that Lisa and I have provided already today helps give you a better sense of the components of the CPD. And, not knowing intimately that particular program, I think what I can say is our program is unique in many ways. One being we have 9 professions, close to 17,000 individuals that will be participating in a harmonized approach to quality assurance and continuing professional development. That has multiple components. I don't know the specifics on that program, except to say that yes, there is guided self-reporting, but there is certainly some structure to that through our inventory of learning and the inventory of risks and protective factors. I don't know if you wanted to add anything more than that, Lisa.
Oh, thanks, Kathy.
Thank you both. Another question in advance. Some clinical practices have had different levels of requirements in terms of training and professional development across the professions. How are we keeping the public safe and ensuring clinicians are highly trained when those requirements have been removed and professions with less education, training, and regulation are not held to the same standard?
I'll start with this one. I would say that we're not removing requirements, so I guess it depends what we mean by requirements. But to me, the requirements for you as a health professional are that it's your responsibility to practice safely, ethically, competently within your scope. So, and the new program is based on standards, will assess professional performance, and still has a very strong requirement for professional development. We're just giving you more flexibility in determining what that professional development may look like. So I guess I'd say that, we have different professions with different educational requirements, different scopes of practice, and different levels of risk with our different professions, but the same expectations apply to everyone to provide safe, competent care. Anything you want to add to that, Kathy?
No, I think, yeah, I agree.
Terrific. Thank you both. I'm going to go to the questions that we've received live this evening. This one is really interesting. How does the return of CPD reconcile with one of a previous presenters sharing that CPD wasn't effective? And I suspect there might be a definition piece in there about what CPD is versus what credits or continuing education or quantified CE might be.
I'm happy to go first, Lisa.
Sure.
I think you're exactly right, Michelle, again, it's familiarizing ourselves with terms that various legacy colleges used. And we may use the same word, but mean something different. And so, this is one of many amalgamating harmonization processes is being able to clearly define what we mean by certain terms and phrases. And within our new program, continuing professional development includes aspects such as completing a continuing education activity. It also includes self-reflection. It includes reflecting on the knowledge that you may have acquired during that continuing education activity in terms of how you will apply that new knowledge in your practice and what you will do to mitigate any potential risks to your patients by applying that knowledge that you've acquired during a continuing education experience. I think the key here is that although licensees are not required to provide verification they've completed a certain course or only can complete a course if it's been accredited, for example, or you need to complete a minimum number of hours, it's expected that all licensees have and will continue to actively, intentionally participate in continuing professional development throughout their career. And we certainly recognize that, we value that, and that is why we have continuing professional development is front and center as an annual requirement that all licensees need to actively engage in and report on. Lisa, I don't know if you want to add anything more.
I don't really have anything to add, I guess, it's true. You think about, the old model or that I had as an old model when I was working as a regulated health professional of counting or collecting a certain number of credits. I have to say that when my legacy college moved away from that, it was an interesting process for me to go through to see how I thought differently, maybe is the right word, about the type of professional development that I was then doing and what that meant for safe patient care. So it's just a different way of looking at it. But what the literature shows is that quantified continuing education credits differ from what true professional development looks like.
Right. I think one thing I would add to Lisa, and you and I spoke about this, we talk about this a lot.
Yes. Yeah.
First of all, I'll say I am a licensee. I'm a speech language pathologist, and in my legacy college, I needed to acquire and report a set number of continuing education hours. So this also impacts me directly too, in terms of how I perceive continuing education in CPD. Is that under the HPOA, the requirement is assessment of professional performance. And that can be through guided self-assessments or direct quality assurance assessments. But reporting a set number of hours that you've completed is not an assessment of professional performance. So I think that's one key difference as well.
Yeah, and I think what you see once you go through the inventory of learning a couple of times,
Yeah.
you'll get a better feel for what it's like. We did that. We did a test run on it a couple of days ago, and it really was great reflection for me to go through it. I'm not even a regulated health professional anymore, and it was, a great experience just to think about what professional development I've done in the past year, what the impacts might be.
Thank you both. Kathy, I know you listed off a couple examples of what would qualify for CPD. There is a request here that perhaps the college would publish a list of what kinds of activities are accepted and those that are not. Do you think that that's something that the college would be doing, or is it more of a professional determination to define what your CPD is?
I would say the latter, because context matters. Individual professional needs can change over time. And when you consider continuing professional development, yes, absolutely, focused on your clinical skills, but there's also many professional skills or related areas that you may want to further development in. The college is not an accrediting body. We don't accredit courses. And we certainly don't want to limit licensees if we set out an established set of courses. Again, we don't want to send the message that we're limiting licensees in terms of what they contemplate. In the inventory, again, when you do that feedback survey soon, you will see the types of information that you consider. They're broad categories such as the type, conference, workshop. It also asks if this is for yourself, personal learning, your individual learning. Is this for employer-based learning? Is it for team learning? So you'll see there's a variety of large buckets, but in terms of actual courses or experiences, we need a lot of agility and flexibility to meet licensees where they're at and where their learning needs and interests are.
Yeah, I would agree. We can certainly provide some examples, but we're not limiting it at all. There's lots of different options for ways to get valuable learning.
Thank you both. We do have a number of questions left, but perhaps if we move on and see how much time we have at the end to answer those.
Sure. Okay, next slide again. All right, so we're jumping back to the slide I had at the beginning. As I said at the time, the HPOA is woven throughout every aspect of the design and development of the new program. The guiding principles are built right into the HPOA. They're not an option. They determine everything that we are doing. And the HPOA has some very specific requirements for QA and CPD. A couple of things, and we're going to go into more detail on this, but there's new terminology, things like the quality assurance assessors, quality assurance officer, quality assurance programs were optional under HPA, but they're mandatory under HPOA. Education for quality assurance assessments that are focused on assessing licensees' performance is required. And previously, assessment and remediation was optional under HPA, but it's mandatory under HPOA. So it just takes a very different approach, and really it's more preventative versus remedial, which is great. And again, all of these things on the screen together is what we're using to inform and guide all of our decisions around PQPP. Next slide. So I wanted to highlight the guiding principles. I'm not going to read them all out to you, and they're on this slide and the next slide. So Naomi, you can change in a minute while I'm talking. They are a new thing for us as regulators. There are no guiding principles in the HPA currently, and they can be the guiding principles apply in exercising powers and performing duties under the HPOA. So they must be incorporated intentionally into the design and development for us with PQPP. Okay, next slide.
Okay, back to me. So turning now to the specific QA program requirements that are outlined in the HPOA. Fun fact, when I was comparing the HPA against the HPOA, there were 25 references to quality assurance in HPA versus 79 in the HPOA. So that tells you how much more focused the new statute is in terms of requirements, the must-dos around quality assurance. As Lisa mentioned already, while the HPA provides permissive May framework for colleges to establish a QA program, the HPOA creates an obligation for colleges to administer a specific quality assurance program. The new statute also states that this mandatory program is for the purposes of improving performance of individual licensees, identifying issues of professional performance across multiple licensees, and also to recommend remediation to address these issues. Continuing professional development is defined in the new statute as an activity or program undertaken for the purposes of ensuring that professional knowledge, skills, and abilities remain current. However, the quality assurance program can't be solely for the purposes of continuing professional development. As I already mentioned, certainly here at the college, we recognize the importance of CPD and that active intentional engagement in CPD is critical to support individuals improve their practice. Hence, that's why we focus so much on the annual touch points for CPD. The HPOA clearly reflects that this mandatory quality assurance program is an assessment and assessment focused, and that the QA assessment program will need purposeful and defensible selection processes and criteria for assessment related to any risk presented by a class or a group of licensees. So let's talk a little bit more about the concept of risk. And this is a very interesting topic for me and others that are very much designing and developing the new program. So next slide, please. So I just mentioned my interest in this. I could dedicate an entire webinar series on risks and protective factors, but today I'll provide a general overview of our intentions to develop a framework in this area. As mentioned previously, licensees and others will have the opportunity to review and provide feedback on the inventory of risks and protective factors sometime in the spring. In that survey, certainly more detailed information will be provided about the inventory itself, as well as the framework that we are designing and developing of these risks and protective factors. But again, this framework is very much in the early stages. So although I'd love to be able to give more details, I can't yet because it hasn't been completely formally developed. But certainly there'll be lots more to come on this topic. This framework is going to be utilized to support the annual CPD risks and protective factors inventory. And also, it will help inform the selection criteria to determine who may be selected for quality assurance assessment. The development and eventual use of this framework is driven by the HPOA. We know that the types of risks that the HPOA expects us to monitor include types of care and services, clinical practice and other work settings, and the knowledge, skills, and abilities of individuals that provide care and services. So, how do I identify? What are the risks to patients and the risk to competence at a group or population level that can help inform us and inform you through guided self-reflection and to help inform a risk-informed approach to selecting licensees that may benefit from more individualized QA assessments? It's a big question. The majority of literature published in this area is focused on physicians and nurses, as well as a smaller amount based on physical and occupational therapy. It's been established in the literature that for these professional groups, there are a set of risks that signal who is more likely to experience challenges with meeting practice standards, and factors and patterns that are known to support professionals with meeting or exceeding standards. During our current development stages of the framework, we're focusing on these established factors to inform the preliminary design of the framework. But this framework will certainly evolve over time as our own assessment performance and participation data grows specific to the 9 professions. So some examples of risk published include transition to a new area of practice is considered a risk factor. If you've been out of practice for a very long time and you're re-entering, and those who are not engaging in any continuing professional development. Some examples of supports and protective factors established in the literature include actively engaging with your professional associations, intentional continuing professional development, and surrounding yourself with a network of professional colleagues and mentors rather than working in isolation. You can read more about risks and protective factors in the Ideas and Design report that's published on the PQPP website page. Lisa is going to be discussing this report in a little bit more detail in a few minutes. Next slide, please. So when developing the assessment tools and activities for our new program, the features of this assessment-focused program need to be considered. So certainly no single assessment tool is sufficient to assess licensees' performance, given the variety of practice settings, the variation in risks to patients, and variations in licensees' learning needs and interests, meaning it's not a one-size-fits-all. The challenge is to develop a comprehensive program of assessment that has coherence in design features and a selection of complementary and effective quality assurance assessments and activities. These assessments need to be accurate, feasible from an operational and economic perspective, and that are fair, transparent, and defensible. As we've shared earlier today, the new program will include a variety of assessments for different purposes. These include focus on assessment for learning, such as the guided self-assessments of inventory of learning and your own inventory of risks and protective factors. Additional assessments for learning and of your learning, such as an open book standards quiz that you'll all be completing in the fall, which is based on the learning module to review those standards, and also individualized assessments focused on assessments of learning, meaning those follow-up quality assurance assessments that are focused on supporting and remediating whenever it's indicated. Each of these assessments for learning and of learning aim to assess your professional performance, that is, your ability to meet practice standards. So, we've provided you with more specific information about the components of the new program, which include annual CPD touchpoints, practice support and resources, follow-up quality assurance assessments, as well as what guides and informs us as we design, develop, and operationalize this new program. I'd like now that we focus a bit more on the process undertaken and what will continue to occur while we develop the new program. Next slide, please. So, way back in June 2024, it seems like yesterday, yet a lifetime ago, that amalgamating process provided us the opportunity to experience firsthand the operationalization of legacy quality assurance programs. So over the last 18 months, staff have experienced from the perspective of each profession, from gaining insight into the initial history that all the legacy colleges dedicated a lot of time to develop their programs, right down to how these programs were operationalized. It placed a spotlight certainly on, I would say, very significant differences in terms of what each legacy QA program was, and I would say the expectations of registrants on what they needed to do to meet their quality assurance requirements. This combined with knowing that the HPOA would eventually come into force certainly provided, I would say, very much an exciting opportunity and a catalyst to create a new harmonized program across all 9 professions. So Lisa, I'm going to hand it back to you to talk more details about the process.
Okay, yeah, great. This slide is just kind of a quick snapshot of all the considerations for design and development. And I'm going to speak to, we've spoken to many of these already, but I'm going to speak to bylaws in a minute and also the various partners that we sought input from. 2 things that are on here that we haven't really talked about today is policy development. So I know I said at one point that, the feedback that you're providing us is super valuable. And even if you don't see it necessarily reflected in some of the things like standards, et cetera, that you've, provided feedback in, we are using that to help develop policies and standard operating procedures. So we have a pretty solid list right now of what policies we need to develop. We haven't done any specific work on them, but we have a good list built out. So that is something else that we are working on. And platform development. Of course, we need a platform to host this new program. So we're actively working on that right now, and we'll have it, in place for the fall as well. Next slide. So just some of our partners in design and development I wanted to highlight on this slide. And I also wanted to say that our quality practice team brings strong internal expertise in regulation, standards, professional oversight. And we have staff that have significant experience in education, post-secondary education, and development of educational tools. Designing a valid, fair, defensible, feasible, assessment program requires specialized expertise. So we have certainly sought this out to ensure that we're looking at, the most up-to-date evidence to support this design and development. Okay, next slide. So Kathy has already mentioned quickly the ideas and design report. You'll notice on the last slide, you might have seen SGT and Associates as one of our partners. And so we've been working quite closely with Dr. Susan Glover Takahashi, known as Sue GT, and her team. Sue is an adjunct professor in the Department of Family and Community Medicine at the University of Toronto, and she teaches in and researches curriculum, assessment, and remediation to support health professionals' confidence. So we've been working closely with her. We went to her and said, here's all the programs we've got. Here's the requirements in the HPOA that we have coming up. Can you give us some ideas? And so she provided us with that ideas and design report that, as Kathy mentioned, is on our website. It is, if you go to the registrants tab and then PQPP, you'll find it, a link to the report in there. If you've got questions about the whys for some of this, I would definitely look to that report. It's got so much information in it. And when we were consulting with the Quality Assurance Committee and provided them with a copy of the report, the feedback that we received at the time was that the report and the evidence was extremely helpful for them in rethinking some of the legacy requirements and programs that they were coming from. So I would highly encourage you to have a look at it if you have not. Next slide. So speaking of our Quality Assurance Committee, I wanted to share some quotes that they provided me after we had a meeting last week. We were meeting with them about the new program. And so I asked them, would you be willing to say a couple of words about the new program? And so these were three that I thought I would share with you today. And I also want to extend my gratitude to the Quality Assurance Committee members. Under the HPOA, there's no requirement for a Quality Assurance Committee. It's not a statutory requirement. So they'll continue to be actively providing input and involved in the design of the new program, design and development of the new program, right up until April 1st. In the draft HPOA bylaws, we've included the option for a quality assurance group, and that group will provide professional expertise to inform the operation of the quality assurance program. So again, big thank you, committee members. We appreciate everything that you've done to help us with this. Okay, back to Kathy.
I think just very briefly, this slide. So the HPOA draft bylaws specific to quality assurance and CPD. So these two sets were published for public consultation back in August and September for quality assurance, and for CPD in September and October. We received a lot of feedback, which we very much appreciate. And as with all other feedback received for the other parts of the bylaws, Joanie, thank you, went through each and every question and feedback. So we definitely value all the feedback we've received. And it also highlights in this feedback the areas that still need some refinement. And I know Joanie and team are working in earnest on those refinements. And it also, the feedback helps signal potential policy and operational considerations while we continue to design and develop the components of the program. So Lisa, back to you, a bit more specifics about the feedback and the bylaws.
Sure. Thank you. As Kathy mentioned, Joanie has read every single submission and, then passed all that on to us. So for the two sets, we had the QA draft bylaws that closed in September. And then for continuing professional development, it was in October. You can see the number of submissions received for each part on the screen. I will say that our sequencing for all of this has been a little bit out of order, which I think has probably caused some of the confusion. The bylaws came out first before we'd really even started development of the new program. And the reason for that was simply the timing of the HPOA implementation. So normally we wouldn't have gone that route. We would have developed the program, policies, etc., and then drafted the bylaws. There has been one change between the initial consultation and the full set that went out for the second round of consultation in December. And I said it already, but I'll say it again, even if you didn't see your feedback reflected in the new draft set, we are using that for all of these different things, mainly the policy development. A lot of the comments are things that we need to address in policy. So we are actively working on that right now. I'm hopeful that, we've addressed most of the themes that we heard during the bylaw feedback today with this presentation. And if that pertains mainly to the quality assurance assessments, please know that we don't know all the details yet, and we haven't designed and started development, but we will be, and we will be doing more consultation on that in the fall when we get started working on that part. Okay, next slide, please. Quickly, as I said at the beginning, it's a lot. So we started it with the yellow dot for today and showed you going forward. And now we've been, picked up from amalgamation to today. Just thought I'd put it all together. Again, we did this kind of out of sequence today, but here's kind of a snapshot of everything that we've talked about. And next slide. This was our goal and objectives. So I'm hoping that we've met all of these for you today. And just kind of a quick snapshot again of what you can expect next. I know you're getting a ton of communications about things, but we can't not communicate what's coming up. So please watch for future communications about the program. Check the website. We'll keep the website up to date with most up to date information. So please keep looking at that. As Kathy mentioned, there's going to be an invitation in a licensee newsletter for those that are interested in participating in the inventory of learning and the inventory of risks and protective factors. And I highly encourage you to participate if you are interested, because it does you can give us feedback that way, and that's what we're really looking for. So please do participate if you are able. And then in the fall of 2026, you'll be completing your first annual CPD touchpoints. Reminder about upcoming licensee webinar series. So the discrimination one on Feb 4th, complaints, discipline, and support March 5th, and then the harmonized ethical and practice standards on March 18th. Okay, I guess we are at a point where any other questions?
Thank you both. So yes, we still have a lot of questions. Oh, I see some applause. Lots of appreciation coming through as well. One of the questions you received in advance is, what is the difference between an assessment and an investigation?
I can tackle a little bit of it, Lisa, and then I think this might be a combined effort, even maybe with Joe and E, but I'll give a go first. So under HPOA, quality assurance is there to assess professional performance. It's not an assessment of competence or competency. That is over in the investigation side. In quality assurance assessments, we are there to support registrants. It's preventative in nature. We are not assessing clinical skills specifically, but more in terms of supporting licensees so they understand how they can best apply their standards in practice. The other key piece, and the HPOA clearly outlines this, there's a clear firewall or line in terms of information, quality assurance information, which is any information collected about assessments that licensees participate in, cannot be shared outside of quality assurance officers, except under very specific circumstances. Those include imminent risk of harm to the public, and that's very similar to the HPA duty to report, where any regulated health professional has a duty to report if there is concerns around public risk. The other one is all licensees have a duty to comply with their licensee requirements, so they need to comply, and if they don't comply, there is certainly a pathway beyond quality assurance to address that. And then the third one is if during a quality assurance assessment a health hazard is identified, we are required to report that outside of the quality assurance program. Licensees are first and foremost responsible for providing safe care. Quality assurance is not going to be there every day in and out, looking over your shoulder, assessing your practice. We're there as a supportive tool. The vast majority of individuals we already mentioned are meeting or exceeding practice standards. And those that may be at risk at a group level for potentially not meeting or are challenged by the practice standards, we can provide individualized support for that through a QA assessment. Lisa, did you want to add or Joanie?
Yeah, that was a really good answer, Kathy. For me, I was just going to say that, we're going to be assessing your understanding of how to apply the standards. And if say the initial assessment or part of an assessment shows that there is a gap, then what we are wanting to do is help you in improving in that area and addressing that gap, which is completely different than what an investigation would be.
Yeah, maybe I'll just add, not that anyone likes to hear section of legislation, but Section 98 of the Act really clarifies that a quality assurance assessment is not for the purpose of an investigation or disciplinary proceeding. So those are two things that are different, and really the purpose of the quality assurance program as mandated by the Act is to assist licensees to improve their own professional performance. And the Act refers to the individual licensees. So there are a portion that mandates the college to develop those quality assurance assessments with those purposes. But they are meant for two different things, and the college could not do a quality assurance assessment for the purpose of an investigation. There are only very specific circumstances that would force the college to actually refer the matter to an investigation because there's some immediate risk to the public that is uncovered through this process. So yeah, thanks, Kathy.
Great answers. Thank you. I'm seeing a number of questions in the Q&A feature about the evidence that we've used for this, and specifically the evidence around risk and protective factors. I have posted the link to the ideas and design report in the Q&A. Kathy and Lisa, is that the best place to go for the links to the evidence that we've used?
Yes.
Definitely.
Yes. And in addition to that very comprehensive report, there's an executive summary report as well as the full report. There is a significant list of references in that report, some of which speaks to risks and protective factors, and what's been published on this topic over the last 10 to 20 years.
Great. Thank you for confirming that for me. We did receive a couple questions in advance, and I know you folks have addressed this in the presentation, just around confidentiality and patient records, and within a QA program, pulling patient records. I'm wondering if you could just reiterate that, and also if there's any stipulations around informed consent when engaging with a patient on, perhaps if the college is going to pull a record. We did receive a few questions on that and what that might mean for health practitioners.
What do you think, Lisa? Do you want to give a go? Do you want me to give a go?
I can speak to the informed consent piece, and then if you yes, I have provided also an answer in writing that will appear in the Q&A that someone specifically asked, because that's something we now need to kind of include proactively in our consent. And so not to read again what I've provided in the answer. Like, the duty regarding informed consent is to provide patient with the information that a reasonable person would wanna know to make an informed decision. So, of course, that sounds very vague. It's because it's not black and white. It's usually very patient dependent, and it is related to the type of services that you are provided. Usually courts will kind of look at what a material risk is, and then kind of look as if the health professional has provided information regarding a material risk. So In the case of a quality assurance assessment, um, as we've mentioned, we do not anticipate that we would, first of all, audit all licensees. And it's not all audit that will actually include a review of record, which is kind of like another step. The likelihood that one of your patient record at any time would be audited becomes more of probably a speculation than a high likelihood. So it is most likely something that you would do on a patient case basis if you are selected for a quality assurance assessment. And we are noted like informing you that reviewing your records will be part of this assessment. We will work with you to identify which records that would be. If you identified a risk in one of your patient's record, this is when we should this should be discussed and you should notify your patient, and you could raise this to the college and the patient would have an opportunity to deny or not consent. So this is really how we would kind of approach this. And again, maybe easier for people to read the answer I provided in the Q&A comments so you can kind of digest and absorb this. But this is what we would kind of expect health professional to do, because it might be possible you're never audited, or if you are, that it does not include a record review. And so proactively disclosing something that may not ever happen might also cause some harm and damage and breach of trust with your patient. In terms of confidentiality, I'm not sure if like the question was more on if it's related to the records or, but I think I would just kind of mention again that these are enabling authority that are being provided to the college. And really grounding this in the purpose of what the Act is expecting the college to do with this program, which is to improve your practice. And those are not going to be done with the intent of actually as an investigation, as we've just discussed. And like we will kind of continue to share more information as we develop those policies, so everyone is really clear about how these will work, how we will protect the security of records if we would actually, include that. And as an organization, we are also having to comply with legislation that protects patients' information. It is something we're already having to comply with. And we're already doing, because that was part of other programs in the past. So Lisa, Kathy, I'm not sure if you want to now complete, but I wanted to kind of maybe provide a little bit of initial information on this.
I don't know, you covered it all pretty darn good. I'm trying to think of what else I would say. I was going to say that, yeah, we are subject to confidentiality, the provisions that are in the HPOA. And that, yeah, some of the pieces that we know have been the areas of concern for this mostly relate, I think, to the quality assurance assessments. And we haven't started building that yet. So we'll certainly keep all this in mind and we'll consult with you as we do so.
Yeah, I think the only thing I would add in addition to all of that, thank you very much, Shoni, for that.
Yeah.
Is that, and the HPOA requires this, is that the quality assurance assessor is of the same profession as the licensee. And so in addition to being bound by confidentiality, is that assessor appreciates the sensitivity and the practice context from the same professional lens. And so certainly our mandate is to protect the public and keep them safe, and working collaboratively with the licensee during that quality assurance assessment process to keep that front in mind, I think is really critical.
Great discussion. I have another question we've received in advance that wants to have some clarity on the assessment. If this is a type of peer assessment, will you be contacting my employer and my co-workers for their feedback?
I think maybe it's the word peer. So for a peer assessment, we're saying it's done conducted by, again, as Kathy just mentioned, somebody from your profession. So you're assessed by somebody from your own profession. As for reaching out to, to clients or coworkers or anything, again, we're just not at that point. We haven't built anything out for me to really be able to speak to that. It'll require a lot more level of consultation to figure that part out. Want to add anything, Kathy?
I don't think so, except to acknowledge, yes, it's certainly in the bylaws to do that. But again, we're not nearly there yet. Lots more consultation would need to happen. And again, with the, at the front of our minds is protecting the public, and we're certainly do not want to disrupt the day-to-day activities of a clinician, and that is right in the act itself, to keep patients safe and feel safe throughout the process. So.
Yeah, good points. I'll just add that the college would not contact the employer before the licensee in the course of a quality assurance assessment. So that assessment will always start with you. You guys will know about this. Those are subsequent steps. They're not the first one. Never would the college contact an employer before you are contacted and are being aware that you are participating in a quality assurance assessment. And if it is done, again, this is not in the course of an investigation. It would not be with the purpose of finding faults. It would be for the purpose of improving your practice. So it would be to support you, not like going in the, again, this is not an investigation. We wouldn't be talking to the employer. And you would know what type of question and information we would probably ask to the employer if the assessment was going to this step. But again, this is an enabling provision. It does not mean that this is something that would be used. And we will provide more information as those policies are being developed, so people can better appreciate when and how that would be used.
Thank you. Changing gears a little bit, going back to risk factors, how will risk factors differ from discriminatory selection for quality assurance?
Very interesting question. And not fully appreciating the thought behind that question that's being posed. I will say that we're talking about risk at the group level. And we're not talking necessarily about risks that an individual may or may not have. Again, it's based on the group level. And it also doesn't mean simply because you may have a handful of risks, doesn't mean that you are not practicing competently. I think that's the case. I certainly appreciate that we don't want registrants and licensees to feel that we are specifically targeting one individual because they've signaled that they have a specific risk factor. But on the other hand, the literature certainly, there's a significant amount of published work on this around risk factors at a group level that may mean you're higher risk of being challenged at meeting those practice standards. So I would urge all of you to read the Ideas in Design report. It talks about this at great length as well as other references. Lisa, I don't know if you want to, maybe I'll add just a personal story for me. So as a practicing SLP, there were times in my life where I had to step away from practice to raise a child, as well as to help some other family members. And so prolonged periods away from the profession have been identified in the literature as being a potential risk to not practicing in accordance with the standard or standards. But I mitigated those risks. I surrounded myself with other robust team. I sought additional continuing professional development when I re-entered into practice. And so I think, again, the model for the risk and protective factors is there to help guide individual licensees determine what they feel may be risks relevant to them, as well as to address those by whatever means they need to protect themselves against that. And that individuals who are selected for quality assurance assessments is based on the risks presented at a population level rather than an individual level. Lisa, if you want to add to that.
Yeah, no, I think that's great. I think about in the ideas and design report, I think there is an example around sitting for prolonged periods of time
Right.
result in back pain. So again, that's across the group level, right? Whereas I sit for long periods of time every day, and currently I don't have back pain. So it is kind of yeah. And another example that I could use is I had this conversation with my 86-year-old mother the other day who she had to go for kind of a update on her driver's license, and
Mm-hmm.
it was identified that as somebody who's over the age of 80, you are a higher risk category as a driver. And she didn't like that, which I understand, but it's true. She may not have that risk factor, but it has been identified across the group level.
One thing I'll add too is, as a clinician, I know all of us listening today who are clinicians, we consider and mitigate risks every day in practice. It's certainly not a new concept about risk, whether it's from making sure that you have appropriate infection control practices, to calibrating your equipment appropriately, to seeking additional training if there's a new area of practice that you want to be involved with. Hearing screening, vision screening programs are there to mitigate risk, because if you don't identify them, there could be concerns developmentally. And so the concept of risk within the services that all licensees provide is not new. What I think can be new for some is intentionally thinking about your own risks to competence and the risks to patients, both, and how you can do that in a self-reflective way in order to make sure that you're providing competent care.
Terrific, thank you. I'm also seeing a few questions in the chat about the timing of the QA activities that licensees will have to undertake. And I guess it might be unique for some professions where the QAP is being decoupled from a licensure period. And so I'm wondering if you could speak to that and why the fall was selected for quality assurance and why it might no longer be tied to a licensure renewal.
Yeah, I can speak to that too at least to a little bit. And again, feel free to jump in here, Kathy, but um, it's a little bit about sequencing and timing and making sure, like you have to have completed this in order to renew. So we needed to give you enough time so that if for whatever reason you've missed a date or something, we didn't want it to land right on March 31st because that was going to cause all kinds of other problems. And if renewal usually opens sometime in February or right around the beginning of March, it is really administratively heavy for the staff if you suddenly have not completed a requirement and are trying to renew and figuring out which team you need to talk to and how we need to sort it out. So we needed to finish it well in advance of renewal. So a couple options, what do you consider timing wise? June, July, August, not good times to do it. September, not great. We're going to open it up for that learning activity in September. December, not great. And if we start to get into January, we're getting too close to renewal. And we don't want to do it over renewal for you, of course, because that doesn't quite work. We maybe could have started it like April and May, but it just felt weird that you would be having just renewed and now having to report on all of this at that time point. So the decision was made that October, November is probably the best timing. Do you want to add anything, Kathy?
Yeah, I'm just reflecting back to when those legacy quality assurance programs were still in motion, the machines, I call them. So those 7 different machines. Some of those legacy programs, the deadline to complete their quality assurance requirements was on the same day as registration renewal deadline. And it honestly creates a significant increase in workload for staff because staff are both supporting registrants in completing their quality assurance requirements. And we know life happens. Sometimes you cannot complete those requirements in time. And if your profession-specific bylaws state that you cannot renew your license until you complete those, it can be a very stressful time for registrants. And so to be able to provide focused and truly supportive help to licensees in completing their continuing professional development well in advance as a buffer, I think not only definitely helps workload-wise for staff, but I think it gives room for support for licensees if for whatever reason they can't complete their annual reporting by that November 30th deadline. We do have a bit of breathing room to work with licensees on getting them through. And as you mentioned, Lisa, summertime, many people are away. December is often an incredibly busy time for folks. We also wanted to make it very clear that your CPD engagement was over a period of time. It's not just a 60-day window, and that a calendar year made logical sense. January through December, right? This is the frame, 1-year window, where I'm going to be engaging in my continuing professional development. So we wanted the reporting of that engagement to be as close to the end of that 1-year cycle, hence the closer to the end of the year without butting up against the busyness of December.
Yeah, and I think that's important just to stress that again. You continue, your learning and professional development all year. It's just that time frame that you're reporting it and doing the other pieces to the annual CPD, which again, we anticipate that part shouldn't take more than a couple of hours.
Thank you both, and thank you, Joanie. I think we're a little bit over time,
We
so
are.
perhaps some closing remarks.
Yeah, if you just flip to the next slide, even for me, Naomi, I just wanted to say thanks to everybody. Thanks for listening today, and thanks for sending questions in advance. Thanks for engaging with us during this, and thanks to everybody who did this survey on the standards, and for providing those of you who do decide to provide feedback on those other 2 activities we've been talking about, and we'll continue to keep you informed.
Thank you, everyone, for your presence. And we will also keep a copy of all the questions and probably try to develop additional Q&A on the website as over the continuing week. So if we have not been able to answer your question, we will keep a copy of it and try to aggregate similar questions and create some Q&A. So thank you again for your engagement. We appreciate everyone being there.
Thank you.